Prof. Shahrul Bahaya. I'm a consultant geriatrician and I'm also the head of unit here at Geriatrics. We are the first acute geriatric unit here, and we deal with a lot of acute and chronic medical problems in the elderly. And we also run a memory clinic service here that looks at the mood and behavioral changes of older people. So it encompasses depression and dementia as well. So it's quite valid to mention for the.
So where's the
your
memory
question.
clinic?
Memory clinic is here at PPUM.
Yesterday.
It was yesterday. It was every Monday afternoon we've had the memory clinic here since 2005.
2005.
Yeah. So the service has been for over 10 years. So, but there are many more memory clinics across the country now. The geriatric population for memory problems, the clinics are run by geriatricians, also geriatric psychiatrists. So psychiatrists who specialize in old age disease. So old age depression, old age dementia, old age psychosis and things like that. So any psychiatric problems involved. So the geriatricians and geriatric psychiatrists run the service. Yeah. So we have about 27 registered geriatricians in the country, and but I think somewhere around just under 15 geriatric psychiatrists who are who've registered and also are in training. So tak ramai. And our aging population is increasing.
Yes.
Yeah. Right now,
Going to aging.
Yeah, and by a few short, by 2030, kita dah aging nation status. So at least 15% of our population will be over 60.
Yes.
And we're not ready for this. Dari segi
Healthcare.
healthcare, infrastructure, economy, finances, everybody's growing old, but Malaysia is not prepared.
Yes.
Yeah, Malaysia is not prepared in not just the infrastructure, the health and things like that. I think it's also the mindset. Sebab kita dulu pension 55. Umur 55 bagi saya is very very young.
Yes.
Still, yeah.
Still work.
Yeah. So now we've increased the retirement age to 60.
Right.
Hopefully we will increase it further. Yeah, because the capacity of the older person to work, to be more socially active, to be physically active, to be mentally active, should be extended. Sebab kalau dah pension by 55, 58, there's a whole lifetime of inactivity, both physically and mentally. So that can breed a lot and start a lot of physical, mental and social problems amongst our aging population. So that's why we need to improve. We need to get a lot more education and awareness about the changes that occur when you grow old. So that's what part of the things that I teach my students is how does an older person change? So it's from what's normal, when you get into pathological aging, and then the changes in physiology as you grow old. And then when that becomes pathology. So there's a lot of grey areas there. So what's your questions?
Okay, my first question is, what is Alzheimer's disease actually?
Okay, Alzheimer's disease is just it's a disease that is under one big umbrella term of dementia. It's a type of dementia. It's the most common type of dementia. 70% of Alzheimer's 70% of dementia is actually due to Alzheimer's disease. Etiology is mainly unknown, but the pathology there's been research surrounding what the changes are, what the brain goes through. There's a very small proportion of Alzheimer's that is genetic, but very few. But majority are because of various risk factors. So it's a type of dementia, and it's the most common type of dementia. Other types of dementias are stroke-related, neurological disease-related, like having Parkinson's disease. So it's part of one of those irreversible type of dementias.
My second question is, what are the causes of the Alzheimer's disease?
Okay. Yeah. As we talked before, a very small percentage, maybe 2-3%, are genetic. So you have a chromosomal normality, but the majority of it is etiology is not really very known. We just work in terms of what predisposes somebody to, so it's not sort of causes but predisposing factors that put someone at risk. And in a lot of epidemiological studies have shown that Alzheimer's, those who are at risk of a type of dementia are those who are maybe of a lower social class, lower education. But that's not also entirely true, because I think perhaps maybe those who have a lower education and awareness may predispose to more diseases like, for example, diabetes, changes in lifestyle.
Yes.
The smokers, they tend to have hyperlipidemia, basically high cholesterol, more
Because-
sedentary lifestyle.
Yeah, because we went to Rumah Alzheimer last time. They said also the doctor can have the Alzheimer's disease, not
Yes, not just anybody
so
can get Alzheimer's, but it's just that those who tend to have it are more within those who have more sort of population lifestyle kind of diseases, and that's usually those who have lower education, who are not eating the best of foods, who are not exposed to certain types of education, such as the need to stay healthy, to be physically active, to so again it's very much lifestyle. So in Malaysia, sebab kita satu Malaysia when it comes to food, yes, those who are very even those who are very educated, like you ladies here, also makan pun tak tentu kadang-kadang, right?
Yes.
Yeah, we have our nasi lemak for breakfast, our teh tarik to go with it, and all this. And then if this is a lifetime of nasi lemak, roti
Nasi
canai,
lemak,
teh tarik,
exactly.
and all that, at which point you have certain predisposing factors that might put you at risk. I think the biggest risk factor are those who are sedentary, those who are physically, mentally, and socially sedentary. So they are socially isolated. They don't go out. They don't stimulate their mind. They don't. Yeah. But these are also diseases that this sedentary lifestyle predisposes to cardiovascular and cerebrovascular risk factors, and this then leads to the different types of dementia, which includes Alzheimer's. Our population in Malaysia is not who get Alzheimer's is not similar to the Caucasian population, because I think the pure Alzheimer's are truly more Caucasian. In Malaysia, it's more, although the features and the history of the person having progressive short-term memory loss followed by changes in behavior, which may include depression, may include anxiety, may include apathy, the desire to do things or learn new things is lost, difficulty in learning new tasks or completing tasks, having what we call difficulty in functioning or planning, executive dysfunction we call it. Those are the features of Alzheimer's disease. Now, as I said, contributing factors may be cardiovascular risk factors, so having diabetes, hypertension, hyperlipidemia, smoking, those are disease factors. So those about a higher proportion of our patients who have Alzheimer's, so we think Alzheimer's also have changes in their brain that look like little strokes, deep white matter ischemia and things, and those are common to those who have microvascular and macrovascular complications of diabetes and hypertension. So that is a bit more with our population. It's about there's not too many. I mean, it's still a high number of people who have Alzheimer's who just don't have any other diseases, and they just have this the pure changes that that are associated with disease. But there are higher and higher numbers of older Malaysians that actually have the vascular risk factors, and then they start having these memory problems. So we call them mixed dementias, mixed features. So Alzheimer's plus vascular. Mixed. And then mixed picture dementia, mixed type.
My third question is, what are the important symptoms of Alzheimer's disease experienced by the patient?
Yes, so
What
for the
are
features.
important symptoms
Okay.
experienced by the Alzheimer's patient?
Different people present in different ways. One of the commoner ways in which they present is what I've mentioned. They initially they complain of different presentations. In my memory clinic, some of them come because they feel they have a memory problem. Dia dah cepat lupa. So these are what we call the worried well. So they walk in, they say, their memory not so good. And some of them have what we call mild cognitive impairment, so early symptoms. And then there's another group of patients that come in because their daughter, sons, or their spouse think that the memory is getting worse and they're starting to change in behavior. And then there's another group that come in who are already very much demented and have big behavioral issues. So the early presentations may come as, slight forgetfulness, losing things, misplacing things, getting frustrated when they lose their keys, their money, and then this can progress. So that is basically features of short-term memory loss. Yeah? So it's the cognition, the memory. But there are also other domains that are affected, not just memory. Then the mood may be affected. So if you are, say for example, you're forgetting things, and then if you are going out and you are socializing, and you're having a conversation with your friends, and it becomes obvious that you're not so connected anymore. You start repeating yourself, then you become a bit more socially withdrawn. So tak nak keluar sangat, tak nak socialize, don't want to socialize so much. So then it starts also with some features of depression. So then you feel a bit low, down, don't want to mix so much. And then when you're out socially, even if you're out socially, although it looks quite normal, you don't look, that there is anything wrong with them, but they don't engage so well in conversation, as they used to. So that's another change that people see. Another one is repetitive speech. So from asking about the same question again and again. This often brings, this is what the caregivers, the children, the spouses always complain of. Repeating and repeating and repeating themselves. So repetitive speech will be one of the signs in which the patients come in with, but the caregivers are the ones that complain, keep repeating the same thing. And this then becomes like they tend to argue with each other. Like, why are you repeating the same thing? What is going on? And it becomes, rather than it becomes their fault. Because if we understood the disease, that is the sign that actually dah cepat lupa. And arguments would be much less if family and basically the community at large understands the disease. With Alzheimer's also, 70% of the people who suffer from Alzheimer's present with behavioral and psychiatric symptoms. We call this BPSD, Behavioral and Psychiatric Syndrome of Dementia. And it's quite common where they become quite agitated. Go out and then they get very upset, or senang cepat marah, get anxious, become very sometimes aggressive, cari gaduh with neighbors, get very argumentative about certain things, or maybe disinhibition, become very disinhibited. So would talk to strangers, become very elated, euphoric, talk about things that are not related. Talk about politics. Itu bukan BPSD, itu biasa sekarang. But they get easily riled up. So that's also a behavioral element, and some can get very, very severe, such that there are symptoms of sundowning. When the sun goes down, the person becomes more agitated. All these stories about when the moon is full, and bila dah maghrib kena kacau, all this and that, pergi berubat bomoh dulu sebelum jumpa doktor. It's actually signs of sundowning in dementia. So it's so they present with delusions, fixed false beliefs. So orang ni, my neighbor is stealing my plants, my neighbor is doing this to me, my neighbor has called the police, I'm going to call the police because my neighbor is doing. So those kind of delusions, we call it, delusions. And then, or you know, the wife may think, oh, my husband's having an affair, I know this is the case, and then it becomes out of control.
False
But the house
belief.
is a fixed false belief. So they are fixed on an idea, but it's false.
Okay.
Or maybe there is some truth to it, but it becomes 10 times worse because of the condition. Hallucinations. They see things more than hear. Hearing is more schizophrenia, but auditory hallucination, visual hallucinations is more common. So this is where kalau orang Melayu kita dah pergi bomo dah jumpa dah ada orang kacau, ada benda kacau, padahal it's actually a disease. So it's part of your BPSD, your syndrome. So that's how things present. Different people present different ways, and different ways in different stages.
Different stages.
And it really depends on, for example, if you say those who are of lesser education get Alzheimer's or any type of dementia early on, but the progression is slower.
Okay.
Those who are more aware and educated, it's very difficult to detect because they will have coping mechanisms to hide, to cope, to present differently. They still are out there in the community, they're driving, they are doing their finances, they are still heads of industry, but they have memory problems.
Yes.
But the deterioration, they get it later, but the deterioration seems to be faster. Yeah. So there are certain studies that have looked into this. Yeah. Okay.
Maybe my question have been answered.
What's the question?
When the patient start showing the symptoms?
Okay. Usually, it depends on the individual. It's very much a case to case. Those who have specifically Alzheimer's disease, they may start showing subtle signs as early as 8 to 10 years before. There's a prodromal period before the disease starts to manifest. They may start having, this is where when we assess in memory clinic, we just don't do the memory scores. We look at how they function. So things like their instrumental activities of daily living, are they able to go out of the house without anyone following them? Are they able to do the shopping independently? Are they able to take the medicine independently? Are they able to use a smartphone or mobile phone? Are they able to make telephone calls by themselves? Are they able to drive? Are they dealing with their own finances? Are they paying the bills on time? Are there any subtle changes that might show signs of early signs? Yeah? So this may be going on for some time. And those signs may come, those deterioration might come first before tiba-tiba tak nak mandi, digelam malas. The spouse says, he's so lazy, he doesn't want to get up, he doesn't want to bathe, always he doesn't want to shave anymore, losing interest, apathy. So those functional things, and then you sort of go back to the history, it's probably been a progressive deterioration over some years. And for example, somebody who's pensioned off, when they were busy working, having a purpose, having a structured day, they tend to not be aware of symptoms just yet. And then tapi bila pension saja, then you start seeing, because there's loss of structure, loss of a timetable, loss of tasks to do that is you're familiar with, and then suddenly when you come out of that situation, then things start creeping up. Yeah? So I think that's quite common. Finding that as the older person starts to wind down from a working life and is pensioned, has more free time, then lack of structure, lack of social contact, social activities, because working is a social activity, you recall. Yeah, because when you work, you are meeting colleagues all the time, you are presenting yourself in time, there is a structure, there is a timetable, there are set tasks to do and to complete by a certain time. When you are pensioned off, there is none of that anymore. So you tend to feel depressed. And then you start becoming a little bit less socially inclined, tak nak keluar sangat. So those who are vulnerable may start showing signs.
Maybe that there is no specific age.
Well, there are those who get early onset and late onset Alzheimer's. So the early onset, very early, say for example, they start having signs as early as in their 40s. Then those are those who are familial subtypes of Alzheimer's disease. Yeah? Those who get later are usually the no particular cause. It's sporadic. It can happen to anyone. Yeah? But with a particular predisposing factors that one must, reduce the risk. So if you were to ask me, how do I prevent myself from getting Alzheimer's? Because everybody can get it. It's basically to eat well, eat a very healthy and balanced diet, exercise, move, always be physically active, and mentally active.
So to have the mental active, we have to supportive surrounding, right?
You need to be in a stimulating environment with people who you can connect with, who you can socially engage with. You're keeping busy doing things that are extracurricular, that are kan Tuhan kata dunia akhirat,
Should
kena
be
buat dua-dua.
Yes.
If you fikir kat akhirat, dunia tak, it's a balance.
It should be balanced.
It should be balanced. It is very difficult. And then when you are in clinic like myself, I'm younger, and then you advise older people about having a balanced lifestyle. One thing that you can also say is just never stop moving.
Never stop
Always
moving.
move. Yeah. So for those who, if you look into our demographics, those who have more diabetes, more metabolic syndrome, more obesity, more of a poor diet is who?
It's
Our
good.
Malay
Yes,
population.
Malay population.
And they're the ones in our demographic, especially the urban, who are, purely dietary and lifestyle modifications that can. Because I have 50 to 55-year-olds, Malay women, low education, who are not working, perhaps at home. They are most at risk. Sebab dia orang masak, the food, the stress, rearing children and all that, so they tend to get bigger. They tend to have diabetes early. They tend to have arthritis, so they are prematurely aging. So if you have conditions such as diabetes, metabolic syndrome that prematurely age you as a woman or as an adult, you are also predisposed to having old age problems, not just physical but mental. Kena jaga tu.
Okay, for the last question, what happened to the brain of Alzheimer's disease? Is there a specific part of the brain affected by
Okay, usually it's associated with cerebral atrophy. Cerebral atrophy is neuronal loss, so the brain shrinks. But there are certain areas that might be a bit more. You look at the hypothalamic regions, you look at the temporal areas. Certain types of dementia, it may be more frontal, so you have frontal lobe, frontotemporal dementias. So you have, so it depends on the pathology, and usually it is diagnosed on autopsy. So even if you have a diagnosis of perhaps Alzheimer's, that you think it is Alzheimer's, when you do a brain biopsy at the end, it's certain features that are different. So there are certain areas you may want to look this up, because if you know each part of the brain has different functions.
Yes,
So the frontal lobe,
temporal,
the frontal
occipital.
lobe is mood, behavior, inhibition, aggression or not, apathy, all there. Temporal, parietal lobe. The parietal lobe connects the dots. Your executive function. Temporal lobe is receiving of information. Frontal lobe is expression of that information. Occipital lobe is with vision and your
Vision.
and so it's all encompassing. So there are different types of dementias that affect different things. But usually, Alzheimer's brain, if you do look at the CT scan, it's cerebral atrophy. There are no strokes. There's nothing. It's just more shrinkage. So it's when you shrink, you have neuronal loss, but certain areas of the brain will shrink quicker than some other areas. Yeah. Okay.
That's all from us.
No worries. Okay.
From can you tell a little bit about the memory clinic? How do you conduct to the patient?
Okay. Memory clinic kita it was started here. The first one in PPUM and HKL, and one in Johor Bahru. So we launched our memory clinic service in three states, and it was via radio and via telephone. We had a telephone service. So siapa-siapa yang complaints of memory loss, we screen
Is it the
the
hotline?
question at the hotline. So we have a screening questionnaire, and then if they score above a certain mark, then kita salurkan kepada klinik memory yang terdekat. Yeah. So this is in 2005. Yeah. And that has spread. Our service in PPUM initially was between the psychiatrist and the geriatric psychiatrist. Now it's just fully run by the geriatricians, and we have walk-ins. We have before it used to be walk-in. Now they have an appointment. Usually we have now greater bulk is not so much self-referral, but referral from other specialties. Sekarang. So from primary care usually, and sometimes from neurology, most times from our cardiologists, because a lot of cardiovascular disease people, they have memory problems, so cardiovascular they then present. So our memory clinic service is only once a week, on a Monday afternoon 2 to 5, and there is where we assess and diagnose the condition. So the patients that come in, we advise to come in with a caregiver, so with a family member lah, who can also provide us a collateral history. And at that consultation, they will be assessed for their memory. We will take a history and then examine them for risk factors of any disease that might be predisposed to the condition. And then they undergo certain neuropsychological tests. So not just a mini mental state examination, they may go through functional assessments as well, whether they can, how they function caring for themselves in the house personally, or instrumental activities such as driving, such as bathing, cleaning the house, doing the laundry, doing the shopping, taking their own medication, etc., as I mentioned before. And then we also have a computer software where we look at, for those who are not literate, we do a visual assessment of memory. So that we have a CanTAP machine. Basically, it's a computerized cognitive assessment software that we assess patients with, to give us an idea as to what are the deficits. So the dementia screen is that, plus blood tests. So if you have medical illnesses that predispose you to being forgetful, for example, sometimes there are things called reversible dementias. So if you have a very low thyroid function, you can't focus, you're tired all the time, you're sleepy, so it may mimic dementia, but you're actually hypothyroid. If you're deficient in certain nutrition, like B12, folic acid, you're anemic. That can also make you a bit, dull, not very difficult to focus, tired all the time. So they may mimic as well. So we screen full blood count. We look at kidney function, because those with kidney failure also may be a little bit more forgetful. Liver function can make you a bit more tired and apathetic. So that also something we screen. We look for calcium minerals, because if it's very, very high or low, it can also mimic psychiatric symptoms. So hypercalcemia, you get very agitated, you get very confused sometimes. So that may present. And then we look at inflammatory states. We do an ESR. We check to see whether any inflammation or infection of the brain can also cause this. We check for certain diseases, infectious diseases like syphilis can also cause neurosyphilis, can mimic dementia. And then we do imaging, neuroimaging, so either with a CAT scan or an MRI of the brain, depending. MRI will give you a better idea of the vasculature, a bit better if we think this is more vascular problems. So it's more for diagnosis and assessment. But what happens usually now in memory clinic, although we are giving the diagnosis, we are assessing, we are finding that we have to do a lot of counselling. Because bila dia orang datang with the family, is the caregiver saying, oh, I cannot deal with him anymore, I am fed up, he's so lazy, or he's so aggressive. Or so it's a lot of caregiver support. So this is where we work together with the Alzheimer's Disease Foundation to help caregivers, give them training, give them education and awareness, give them ability to cope with certain scenarios. Where, because a lot of the treatment, when we're going on to treatment, a lot of treatment for Alzheimer's is actually non-pharmaceutical. Non-pharmaceutical, where you have to first be aware and know how this disease presents, and then you can modify the environment a little bit so that there is less triggering factors to get the patient, or stimulate them if they are very apathetic, or if they're very agitated and anxious, then you create a calming environment. And most important thing that we teach the caregivers is that, because it's they've lost someone, they feel as though they've lost the person that they love, or the patient is no longer who they recognize. Dah berubah sangat, dah lain daripada dulu. Kenapa tak boleh buat ni? Kenapa tak boleh buat tu? Why? So they're grieving actually. So it's for us to sort of say, actually, this is a disease. They're not doing it on purpose. They are, changing, and we have to. It will get worse before it gets better. There are ways in which we can train you to understand, but a lot of it is to do with acceptance. Yeah? And a lot of people can't accept. And that's where, once they get past the acceptance, then they will be a little bit less angry, less resistance. Because sometimes you find husbands and wives shouting at each other when they come. Why are you like this? I can't stand you. And then the person that has dementia only doesn't remember the fight or what it was about, but remembers that his wife or her husband is always angry and shouting at me, but they don't know why, because they forget. Yeah. So there's a lot of counselling, understanding, love involved in this. So if you come to our Alzheimer's Disease International, our Alzheimer's Disease Foundation punya conferences, we have a lot of caregivers. Like we just in September we did a caregivers Alzheimer's Disease Caregivers Conference. You guys should have come for that. Your lecturer didn't contact me. It was last month, but we do it every year. And we have the patients come. We get the nurses to kindly look after and keep an eye and on the patients. Then the caregivers listen to the lectures. We do workshops. Some of the caregivers even give their experience on how they're coping with things. Counselling. Some of them are trained counsellors already now. Yeah, because so that's how you get to learn a little bit more about coping. It's very, very sad disease. It's very sad, but it's also some caregivers will say it's very enriching. It's taught them a lot. Banyak sabar. Banyak sabar. And yes, we will have somebody in our lifetime, somebody we love, suffering from this. It's more common than you think. More common. So now you guys are educated on this. Is to identify the early signs and get the person to see a doctor to check on their health, blood pressure, diabetes, diet, lifestyle. Awareness of health.
Yes.
Because when health goes down, is where these things come up.
About the behavior, we can assume that when we suggest them to see doctor, but they deny how to.
Okay, I mean that can happen with other people, because I've got patients who, the husband has been suffering for a long time with dementia, so the daughters and the wife have been trying to get him to come. So we've got to actually create an opportunity for him to come lah. So sometimes the wife pretends that She is the patient. So I see the wife, and then in the end, I said, "How do you think your wife is?" So I have an assessment of him at the same time. So I'm asking, oh, since you're here, since I'm examining your wife, how do I examine you too? And then so you can create opportunities. Yeah? But it's more of students. We say we have less, a very low numbers of geriatricians and geriatric psychiatrists in the country, but we don't have to have everybody trained as a geriatrician. We have the likes of you who understand and can counsel, who understand the disease. Members of the public can learn. You don't have to be trained in the area to be involved. And volunteering is one of the biggest ways in which students can learn. Yeah? Doing a project like this, you can get to know. Why I wanted you to come to the clinic was so that you can meet some of the patients, because then you can have an interview with a caregiver. They know more about the disease than I do.
Yes.
Because they've lived with someone with it.
Every day.
Every
Right.
day. Every second. And I see them every 3 to 6 months.
So this disease we don't have like medicine that can.
No, there is no cure for Alzheimer's. The cure for Alzheimer's is still on the go. There is a global initiative for the cure for dementia. It is the biggest money-making and highly funded research, much like cancer. Because if you can get over Alzheimer's, because it's devastating, that would be very good. So they are coming out with vaccines, and if you read some research that has gone on where they checked it in the brains of mice, that the amyloid deposition, the neurotoxins that you find if you look at the microscopic slice of the brain, and you find these what you call neurofibrillary tangles. They are due to amyloid plaques that deposit on the brain, and that kills the neurons. So that's the pathology behind it. Yeah? So there is a drug that's been given that can eat up all those plaque depositions on the brain. But that's been found most recently in September. It was published in rats. So if it can happen in rats, they need to go on to further phase 3 and phase 4 trials to actually have human subjects to see whether this will help.
Yes.
But then you talk about amyloid plaque deposition. These are neurotoxic materials that come onto the brain, and these are actually the what do you call the subsequent this is the what do you call the complication of the disease. Bila dah jadi baru you find these plaques. Some people have the plaques, but they don't have dementia yet. So, it's very difficult to sort of put a timeline. That's why people have like a prodromal period of 8 to 10 years, having some pathology going on, and then they start presenting with symptoms when there's already been quite a lot of deposits in the brain already. But these are microscopic, so all you see on the scan is cerebral atrophy. Yeah, so.
I think the last question, how do you cope with the patient when they come to you shouting aggressively?
Okay, you be calm. You be calm, because if you react to that, then you're not helping anybody. One of the things that I teach my caregivers and the students is that when you have somebody who is reacting, you don't react. Yeah, when somebody's being negative, you be positive, so that then you can diffuse the situation. Bring the patient to a quiet room. Be very courteous. Be very pleasant. Apologize. Don't say, "Kenapa pakcik bising-bising ni?" You scold. And you scare the person. That's wrong. Saya minta maaf pakcik, boleh kami masuk bilik ni? Mari kita berbincang kenapa. Pakcik rasa, tolong bagi tahu saya apa dia. And then you facilitate, and then they will have forgotten that. You distract them, and then they will talk about something else. And then you introduce yourself. Always introduce yourself, because a lot of the time when they are aggressive, becoming very, challenging is when their needs are not met. Screaming, shouting, anxiety, agitation is a sign of unmet needs when it's not met. So they are disorientated, they are confused, they don't know where they are. The person that's bringing them has not explained what's happening to them, or even though it's explained, they forget. So it's a vicious cycle. Jadi kalau kita make it more difficult for them, challenge them, get them, it becomes we tell one part of the training for our nurses here, especially when we admit patients with dementia, is that coming into hospital is the worst thing for someone with dementia. Because if you've come to the ward, it's very noisy. There's a lot of activity, and there are lots of different faces. It's very disorientating. So when you find dementia patients having to be admitted to hospital, they become worse rather than better, and then we have to give them sedating drugs, etc. It's because, so there needs to be a recognition of having someone with dementia in what we call the delirium unit, where, those that can be in a quiet, bright, light, calming environment, which is not an acute medical ward. Yeah? So how do you treat? You keep calm and carry on. Because if you are not calm, and then you find the caregiver going,
They're funny.
you've got to actually get banyak counselling actually involved. It's one of the most challenging but also rewarding. And then in the memory clinic we have our own list, so they know you after many years. And then you basically, I've had a man that I've looked after for 15 years, because that is the lifespan. They eventually die. They don't die from the dementia, they die from pneumonia, an infection, complications of their disease that contributed to the dementia. So you build a relationship with the patient and their family. So you take them through the life course, through that deterioration, also although very sad, but if you are hand in hand with the family and the patient with what's happening to them, because sometimes the patient turns around and says, "What's happening to me? What's happening? I'm not myself." But some of them are coming smiling, no problem. But their caregiver is the one that is stressful. They're okay je, relax je. So a lot of the times the memory clinic becomes more for the relative, not for the patient.
So like the patient at the foundation.
Yeah.
At the FM.
Yeah, relax je, smiling, happy, no problem.
They thought they are young.
So, yeah. I'm so happy to meet you guys. At least, there's an interest because you're from a different specialty altogether, and it's nice to have a chat about this. Come over if there's any conferences, please come, because it helps you to, enrich your branch.
Does your library clinic have like website that we can
You can go to the Alzheimer's Disease Foundation website, and then they give you the materials, the information.